Hello, my name's James Belcher. I'm one of the senior clinical fellows in cardiology at the Northern General Hospital. So I'm neither a cardiologist or a rheumatologist at the moment. So I want to just thank Dr. Rachel Tassel, Professor Al Mohammed, Dr. Oliver Watson, Dr. Samina Khalid in putting together this presentation. So why is a rheumatologist, non-cardiologist talking to you today? Well, I've got a case to discuss. So idiopathic recurrent pericarditis, an inflammatory affair between rheumatology and cardiology. So I have no conflict of interest. So the overview of this presentation is to do with is to improve awareness of IRP and the concepts of autoinflammation in cardiology teams, as well as highlight the roles of the MDT in managing people with IRP. And then also highlight the role of new medications, including interleukin-1 antagonists, especially anakinra, and the benefits of treatment with anakinra. So first of all, as we're probably all very much aware, rheumatologists manage immune-mediated inflammatory diseases, but there's been a paradigm change over the last 2 decades. So there are diseases related to the innate immune system, which is termed autoinflammatory, and diseases related to the humoral immunity, which is termed autoimmune. So just as neurologists try and find the lesion in the central nervous system or peripheral nervous system, we need to find where the lesion is in rheumatology to treat it effectively. So we've noticed that cohorts of patients who come into rheumatology clinics don't respond to the standard treatment that they would normally respond to, and these are now recognised to potentially have autoinflammation. Some of these diseases include Still's disease, HLH, Behçet's, Vexus, acquired periodic fevers, and of course IRP. So this is a diagram which shows the spectrum of diseases. So on the left you have your autoinflammatory diseases, and on the right you have your autoimmune diseases, and it just shows you the spectrum there. So autoinflammatory diseases are increasingly recognised as an orphan diseases of autoinflammation, and they do respond to IL-1 antagonists, including colchicine and anakinra and JAK inhibitors. So since COVID-19, we found that it is a profound inducer of autoinflammation, and we've seen a significant rise since the pandemic. And I just want to make one slight alteration to this diagram, and I've put in IRP there. So idiopathic recurrent pericarditis is an autoinflammatory condition, and it causes significant morbidity in patients. 15 to 30% of patients presenting with acute pericarditis will go on to have recurrent pericarditis. However, that doesn't mean that they have IRP. It's only a small subset of them, and we need to tweeze them out. So currently the treatments rely on NSAIDs, steroids, and colchicine. As we all know, these medications have quite considerable side effects that are quite unpleasant, and patients often experience symptoms that are refractory to these medications. So in the new ESC 2025 guidelines for pericardial diseases, anakinra has a class 1A evidence for pericardial disease refractory to standard treatment with a raised CRP, and a class 2AC without a rise in CRP. And this diagram is taken directly from the ESC guidelines, and you can see there that anakinra is right at the bottom. However, anakinra is not funded for IRP in the United Kingdom. It is funded for HLH, Still's, and periodic fevers. So the role of rheumatology in pericarditis, we firstly need to exclude infection, trauma, and then the rheumatologists get involved, and they decide whether it's autoimmune or autoinflammatory, if it's none of the above. So could this be autoimmune, typically caused by SLE and rheumatoid arthritis? Prior to referral for the cardiologist, the rheumatologist would like ANA, ENA, complements, DS, DNA antibodies, urine PCR, rheumatoid factor, and anti-CCP antibodies checked. And then if all of the above is excluded, we would then consider autoinflammatory pericarditis. So yeah, it is a diagnosis of exclusion, and the disease is associated with a significant rise in CRP, which is associated with systemic inflammation, so fevers as well. Without that rise in CRP, it is unlikely that they will have autoinflammatory pericarditis. So I'm going to go on to my case, which is an 18-year-old male who we're going to call Joe. He's normally fit and well. He presented with sudden onset chest pain and shortness of breath during a football match, which radiated to his right shoulder and lasted 5 to 10 minutes. He had a fever of 38.5 on admission, and he describes a 12-month period of fatigue before his acute presentation. His mum is a paramedic, and she recognised some abnormal ECG changes. So his initial blood test showed a white cell count that was marginally elevated, CRP was significantly elevated, and troponin was negligible at 3.4, U&Es and respiratory viral swabs were negative. He had an ECG which showed ST elevation in 2, 3 AVF and V3 to V6, and some ST depression in V1 as well. So he was referred to the cardiology team, and as you can see, he's got a global pericardial effusion there, but the heart is beating fairly well. There's no systolic dysfunction there. He has some right atrium wall abnormalities and some partial collapse, but overall the heart is beating well. So he was diagnosed with his first presentation of acute pericarditis. He started on 400 milligrams of ibuprofen, 15 milligrams of lansoprazole, and 500 milligrams of colchicine. So we had a look at these doses, and we thought that potentially could have had a bit more ibuprofen. The maximum dose is 800 milligrams TDS, and colchicine is a reasonable starting dose, but probably needs up titration to 1 milligram BD. So he was discharged, but unfortunately he represented 5 days later with left-sided chest pain and right-sided shoulder pain, and a fever from 37 to 8 rising to 39 degrees Celsius. His CRP on this admission was 268. And incidentally, he was diagnosed with a chronic pilonidal sinus growing Staph aureus. We did consider whether this was driving a CRP. We don't think it would be, because CRPs don't typically go up to the near 300s with chronic pilonidal sinuses. And despite antibiotics and negative bacterial and fungal cultures, he remained pyrexial. So this was his echo on his second admission. And if you can just see in the top right corner that now the pericardial space has got septations and adhesions in, so it's got quite gunky and mucky in there. So he underwent a thoracoscopic pericardial window and debridement biopsy. The cultures were negative, and his histology showed a chronic inflammatory infiltrate with aggregates of lymphocytes and reactive mesothelial proliferation. And this was his echocardiogram after that, some way through his second admission, and you can see that there is some slight thickening of the pericardium, but the effusion is much better. So there is concern that this patient might go on to get constrictive pericarditis, so he would need to be followed up by the cardiology team. So rheumatology were involved at this point. There was a consideration that he could have adult onset Still's disease, but he had no rash, no joint pains, and his ferritin was only 267 and amyloid was 31. His rheumatology screen was negative. A genetic panel for primary autoinflammatory disease was sent, and the results of this are awaited currently. So he was discharged on 40 milligrams of prednisolone, weaning 5 milligrams every 2 weeks with PPI and bone protection. But he came back to the rheumatology clinic and complained of flushing, insomnia, sweating, increased appetite, and changes to mood, which then settled with a rapid wean. Unfortunately, he was readmitted under cardiology with a CRP of 106, ECGs showing T waves inversion in V2 to V6, and a troponin of less than 3, and he was restarted on steroids. This was his echo on his third admission. as you can see, the pericardial effusion is now gone and the heart is beating well with no evidence of constrictive pericarditis there. So Joe has steroid-dependent colchicine refractory IRP. He's about to start his A-levels and he does not tolerate steroids very well. So we need something to treat Joe with. So a successful IFR for anakinra was made, and we continued this for 6 months. He continued to wean down and stop steroids, and he's had no further admissions since starting this. You can see on the right, the CRP tracking through his admissions. The blue arrows represent his admissions, and the red arrow represents when we started anakinra. And you can see that the CRP is now flatlined from being quite all over the place before. So cost analysis for anakinra. Anakinra is currently unfunded in the United Kingdom, but it is funded for periodic fevers, stills, and HLH. Even though Dr. Tatchell would like it funded for IRP, it is not. So the cost is £40 per 100 milligrams daily subcut injection, comes in a pre-filled pen, and 100 milligrams for 6 months costs about £6,720. I looked everywhere for data on how much 24 hours in an NHS hospital general ward cost, and the most recent thing I could find was 2016, 2017, and it was about £586 a day and 59 pence. But obviously that's variable across trusts. So the total cost for Joe's admissions was just over £23,000. So that you can absolutely see the cost effectiveness of anakinra here. So the historical management of pericarditis utilizes NSAIDs, steroids, and colchicine. These medications are not without side effects, as we've seen in our case here. And steroids are associated with a 4.3 times increased risk of reoccurrence on stopping. Anakinra is an IL-1 antagonist, and it's taken as a daily subcut injection. Site reaction is relatively common, but it's otherwise well tolerated, and it's relatively immune inert, and it doesn't meaningfully increase the risk of infections. Other side effects can include headache, abdominal pain, and hematological changes, and abnormal LFTs. So there is a need to monitor full blood count. Evidence for anakinra in pericarditis comes from the AirTrip-1 trial, which showed that it reduces relapses in IRP compared to placebo, and in IRAP, which showed it reduces acute hospitalization and steroid dependency compared to colchicine alone. And as we've said, it is recommended in the ESC 2025 guidelines. So our case demonstrates the need for cooperation between cardiology and rheumatology in the management of IRP, utilizing rheumatologists as the disease modifying experts. IRP is a diagnosis of exclusion of infection and autoimmune causes, and in the context of a CRP that mirrors symptoms. Current management for pericarditis is associated with multiple side effects, and anakinra offers a steroid-sparing treatment. Thank you very much. These are my references.
Thank you so much. No, another really good case, and nice to see also the variation of cases throughout this day. So grateful to the organisers for having picked such good cases. There's one question from the online audience, Francis Hall.
Yeah, thank you. It's a great case. Just say that obviously, whilst anakinra there's no commissioning for anakinra specifically in refractory pericarditis. If the case does meet criteria for adult onset stills, then both anakinra and tocilizumab are in that policy. Strictly speaking, the policy states it should have tried to convention first, although, as we've just been discussing, this probably isn't driven by T cells and B cells, so that probably isn't going to work terribly well. But I think you can sort of get through that phase fairly quickly. If the patient meets criteria, then through your specialised rheumatology MDT, that's at the moment, although I know Karen will probably come in and talk about the commissioning side for anakinra. Certainly, I know on her radar, which is a bit of a lacuna at the moment. Shuvik has already commented on that in the chat.
Yeah, thank you. To read out, it would be great to see clinical commissioning policy for IRP and MIA. We are trying to get it through NHS England ongoing. Before we come to the question, there's another question in the written text. Given the high cost of anakinra, was the patient tried on another steroid-sparing agent such as methotrexate?
No, we went with anakinra as the first line following the SE flow diagram.
Okay, thank you. And Shufik?
I just wanted to comment or get your thoughts about anakinra and the commissioning policy. I'm the national specialty advisor at NHS England for specialised rheumatology, so it's been brought to my notice. Taryn's mentioned it once or twice. I know Rachel, obviously. I mean, obviously it makes sense. I think one of the questions that's been asked back is, should these patients be managed in specialist centres? Do they need, what degree of expertise of rheumatology and cardiology is required? Do they need specialist MDTs? And that's NHS England is full of bureaucracy, but that's been one of the questions that's been asked is, can anybody, these patients obviously can present acutely and anywhere, and should we be looking at it more a bit like HLH, as in anakinra is accessible everywhere, or what degree of specialist expertise is needed? But just interested in what people think about that.
I think from our case, the use of anakinra, because rheumatologists have knowledge and understanding of how these drugs work, and one of the main points from the presentation is that we should utilize rheumatologists as the disease, the drugs that modify disease. So there should be teamwork, between cardiology and rheumatology, rather than letting everyone have free use of every drug.
Yeah, I quite like. I think Rachel Patterson may have something to say here.
Hi, thanks very much. What a great meeting. I'm really sorry I'm not there, and thanks for accepting the case. Yeah, I think the issue about getting these drugs funded, I mean, I would really challenge that anakinra is expensive. It is not expensive, given there are these these very arbitrary decisions about what's a high cost medicine, and compared, for example, to avacopan, it's and that's why we put the cost analysis in. But I appreciate that there's bureaucracy, and as Shovik knows, it was 3 years of my life to get the anakinra for HLH policy, so I don't envy the bureaucracy, but I think we absolutely should be able, through an MDT, as James describes, to give the correct drug. And the reason we didn't try methotrexate or mycophenolate is there's no sort of theoretical or evidential reason that we would try that, because it's an interleukin-1 mediated disease, more likely than a B or T cell disease. So yeah, those would be my thoughts. And well done to James for coming down and presenting without any of the rest of his supporting team in the audience. Very good presentation and great meeting. Thanks.
Next, I think, is Karen.
Thank you. Yes, I agree with that. Thank you very much, Rachel and James, for a great talk. You'll make a very good point, Rachel, which is about the horrible misnomer of high-cost drugs. These are not high-cost drugs. They are very inexpensive. And that is why we've changed the name of our group, as Shovik will tell you, to the off-tariff drugs group. So we are the off-of-tariff drugs group for England rather than the high-tariff drugs group, to try to get away this label, because it's extremely unhelpful, and trying to demystify the idea that our biologics are difficult. I think one thing that's missing from the ESC guidelines is to talk about, first of all, you may not be treating for 6 months, you may be treating for longer than 6 months. It's very, very difficult to get these patients off anakinra, and that's been a problem reported by Alan Klein and his group for many years. They really cannot stop them, and they've got probably the most experience along with Massimo. And the other issue here is that there is no description in the ESA guidelines for cardiologists about what pre-screening bloods should be done and about infection. And anakinra is very safe in short bursts, and it's good, one of probably the best safety profile of all the drugs that we use in this context, but you should at least check that the patient doesn't have bloodborne viruses, etc. So all of this needs upskilling if it moves away the drug into the cardiology realm. And my worry is that that hasn't been thought about. The operationalization of these ESC guidelines hasn't been thought through properly. So I think that's a challenge for us. I feel like we're going to succeed in getting the funding through. I think Sheffield would agree with that because it's not expensive. But the problem is the denominator, how many patients there are, and collecting the data for the off-label use of it currently, which is a main issue. But I think we'll get there.
That leads to a question on the online chat. What are the clinical biochemical criteria for initiation of anakinra? Are there any solid data on that?
Oh, sorry.
For the initiation in pericarditis.
Yeah.
Yes. So in the what they're using in Italy and the US, which are the two major pericardial centres, they are doing patients who are refractory to high dose colchicine. So they go up to 4 tablets a day, so 1 milligram BD, and then they will be steroid refractory according to ESC guidelines. Now, the problem with that is that there's a lot of evidence that steroids can cause a refractory course, and you've seen that in this case. It's very clear. So exactly as Rachel has said, and I let her come in and answer this as well, but if you start to give treatments that don't really suppress in a targeted way, you're going to end up with refractory disease because you're not really treating it, you're just suppressing it. And I think that is why the steroids are doing this. And so you'd be much better off if once you fail colchicine, if they're really taking it at a decent level, then you need to initiate interleukin-1 therapy. And we should make sure that everyone knows that outside of the UK, there are other options, not just anakinra. It's just that in the UK, that's the only licensed interleukin-1 inhibitor we have. Rachel.
Hi, Taryn. As ever, you've said everything that I would have said and said it much better. I suppose the reason we put the slide in about the doses of brufen and colchicine is exactly that you're not colchicine refractory until you've had 1 milligram BD. And actually following the periodic fever regimen, I often go up to 3 milligrams a day, 6 tablets a day. And people say, well, that nobody will manage that, and they absolutely do. This young man was doing his A-levels, and the main reason that we got a local IFR agreed was that he simply could not get into school, into sixth form, to do his A-levels. And I'm an adolescent physician, and steroids are just meddlesome in adolescence. So I think there's also something about doses. So use the proper dose of anti-inflammatories, use the proper dose of the cheap oral interleukin-1 inhibitors, which are colchicine, but don't, we shouldn't have to maintain young people particularly on high, and that is a high dose of steroids. So what I learned from this is that although we've done quite a bit of work with Professor Al-Mohammed and the cardiologist on our pathway, and now what was gratifying was the patient was immediately started on anti-inflammatories and colchicine. Now there's a bit of work to do on dose and appropriate steroid use. And I wondered if Taryn was going to also say is what, that's why the rheumatologists are useful, because we're incredibly respectful of steroids and worried about them. So maybe you're going to say exactly that, Taryn. We'll see.
I actually just wanted to pick you up on one thing, because first of all, I agree with all you say, obviously, but is you did a local IFR, didn't you? So this is not actually an IFR, because that made I'm sure Shovik is recovering from the shock of it. I don't, just to make it clear to rheumatologists that are on here, an IFR to NHS England for anakinra for pericarditis will do only one thing, and that is take your time, and it will not produce funding for the drug. Agreed, Shovik and Rachel?
Yes,
there's no point in doing that.
Yeah, I mean, locally in Sheffield, our clinical, they have agreed that, I love that phrase, off tariff. They have agreed that off tariff drugs can be discussed on a case-by-case basis. So I've just managed to get mepolizumab at 300 milligrams for EGPA for a young person, and the anakinra, but it's each time it's a cost analysis. And actually the persuasion here was the reduction in a coronary care bed, which I'm sure is much more than £586 a day. But you're right, and we were pushed very hard about what to do after 6 months, and I can often get people definitely to alternate day anakinra, and I've got one patient with IRP who just takes anakinra Monday and Thursday. I've tried twice to stop that and been unable, but £200 a week is an awful lot cheaper than him coming into hospital every time with chest pain. Yeah, I'll shut up now, but thank you very much. Really appreciate the opportunity to discuss.
I was going to bring Rudy Shuglan, who's been very patiently waiting, and I think had a question or a comment, but it's taken his hand down. Hopefully, Rudy, we haven't put you off.
No, thanks, guys. I think I just wanted to most of the points have been covered, but I think the difficulty's been covered really nicely. What we face is the point of patients that have been on anakinra for a period of time, but then stuck that we're not able to access it further. So, Shovik, I think that's the issue, where as rheumatologists, we then start thinking about drugs which we unfortunately have to poison our patients with, things like steroids, which unfortunately seem to be a fallback. So better to use drugs that will minimize that risk, and things like anakinra for IPRP would be great to continue to be able to use for us.
Yeah, just say we are very keen to try and get it through one way or another, so hopefully we will. Thanks.
James, quick question. Is recurrent episodes of fever a common feature of idiopathic recurrent pericarditis?
So usually they would have a systemic inflammation with their IRP. Yes, so you would get fever and rise in CRP.
I've got a patient with a very similar clinical picture, but a different muscle involvement rather than the cardiac muscle. It's the skeletal muscle, but it's a young man and with recurrent episodes of fever and muscle inflammation and very painful myalgia and weakness, and is now hopefully going to start anakinra because he's dependent on steroids. Otherwise, we'll have recurrent flares. But otherwise, it's like same case but different muscle.